the memory of rainy afternoons, swingy Harlem tunes, motor trips and burning lips and burning toast and prunes. How lovely it was. Thanks for the memory of candlelight and wine, castles on the run, the Parthenon, and moments on the river line.
Just the last name of the day.
How lovely it was.
My first name in it too.
All right, thank you very much.
Many's the time that we feasted, and many the times we fasted.
Okay, our next speaker is Dr. Alejandro Tobon. He is an assistant professor of neurology at the University of Texas Health Science Center, and he's going to be speaking about neurodegenerative disorders in Parkinson's disease. So please give him a round of applause. Thank you.
All right, thank you so much. Everybody can hear me okay? All right, so what I'm going to do today is I'm going to have a slightly different approach. You heard a lot about dementia, and that certainly falls in the category of disorders that I'm going to discuss. But I'm going to take the time to approach other common neurodegenerative disorders that you're going to see in the clinic that affect the aging population. I have no conflicts of interest to disclose. So the objectives of this lecture is to describe the scope of the most common neurodegenerative disorders, and I'm going to stay away from dementia. You've heard a lot about it so far, and you're going to keep hearing lectures about it later on. I'll review the classification of these disorders, compare the similarities and differences between them, and also discuss the palliative management of patients with advanced neurodegenerative disorders. So what are those? What is a neurodegenerative disorder, a neurodegenerative disease? Basically, we use it as an umbrella for a range of conditions, and the basic pathological problem is that it affects the neurons. All of them so far are incurable. We have treatments to ameliorate symptoms, to help to manage comorbidities, but none of them has specific cure yet, and all of them are progressive and debilitating. And they're characterized by progressive degeneration of the neurons, and depending on where they are located, you're going to have different manifestations. For example, if you have loss of neurons in the substantia nigra, you got Parkinson's disease. You have loss of neurons in the cerebellum, it's called spinocerebellar ataxia. You have loss of motor neurons, you have ALS, just to give you examples. So far, by far, dementias are responsible for the greatest burden of disease, with Alzheimer's representing more than 60 to 70% of cases. So what are the most common neurodegenerative disorders? Alzheimer's and associated dementias, Parkinson, prion disease falls into this category, motor neuron disease, Huntington, spinocerebellar ataxia, and spinal muscular atrophy, just to mention a few. So as a group, they share different similarities. One, they tend to start affecting specific subsets of neurons. They tend to arise without any clear explanation or without any clear trigger factor. They are progressive. They are age-related, so by far they tend to be seen more in elderly population. And they are associated by pathological changes. If you look at the brains of these patients, that includes that there's neuronal pathology, neuronal cell death, that leads to loss of disappearance of neuronal cell bodies, and it's going to be replaced by glial proliferation, basically scar tissue. There's a lot of phenotypic variability between these disorders. Cognitive impairment and dementia are common for a lot of them, but it's not mandatory. The major risk factor for all of them is advancing age. And it's not uncommon to see that they can share features with each other. For example, there are some types of frontotemporal dementia that can be associated with ALS. And actually there are genetic markers for that. So you can have some overlap. So this is how to classify neurodegenerative disorders. If you have predominantly cognitive symptoms, you establish if it's amnestic, so memory problems, it's most likely Alzheimer's disease. If it's executive dysfunction, it's probably a non-Alzheimer's dementia. And these you can subclassify as a frontotemporal dementia complex or the synucleinopathies. Frontotemporal dementia can be also differentiated from a pathological standpoint if they have positive tau protein, and that includes Pick's disease, corticobasal degeneration, and progressively supranuclear palsy. If it is ubiquitin positive and tau negative, you can have the atypical frontotemporal dementia or the frontotemporal dementia ALS syndrome. The synucleinopathies include Lewy body dementia, dementia associated with Parkinson and multiple system atrophy. Now, if you have predominantly motor symptoms, if it's a movement disorder, Parkinson disease is the most common, and it's a synucleinopathy. If you have trinucleotide repeat disorders, that includes, for example, Friedreich's ataxia, Huntington disease, and spinocerebellar ataxia. And if it's purely motor, then we fall into the category of motor neuron disease, like primary lateral sclerosis, progressive muscular atrophy, or ALS. So what I'll do is I'll talk about three of the most common neurodegenerative disorders not associated with dementia. And the first one, and the most common of all of them by far, is Parkinson's disease. And the reason I chose this cartoon is there are actually studies showing that caffeine intake and smoking is a protective factor for Parkinson. Not that I encourage you to start smoking, but at least it gives me a justification to drink more coffee. So Parkinson's disease prevalence is about 1% in older than 60 and about 4% by age 80. The mean onset is age 65, but it can range a lot. There's a young onset Parkinson's disease. The ratio of idiopathic versus hereditary is 9:1. As I mentioned, there are some protective factors like caffeine, smoking, and there are some risk factors that have been associated. There's family history, so there's certainly a genetic component. Pesticide exposure has been associated with Parkinson, and repetitive head injury also has been associated with Parkinson. So in this particular neurodegenerative disorder, the primary pathology is in the substantia nigra, and its communications with the striatum and the brainstem nuclei. So just to review the basic clinical features of Parkinson, there are 4 basic components for the diagnosis of Parkinson. These 4. Bradykinesia, which means a slow movement, and I'll show you a video just to clarify that. Rigidity, that is something that you can elicit during physical examination. Resting tremor, which is very characteristic of Parkinson and Parkinsonian disorders. And postural instability. So if you have 4 of those, it's very likely you have Parkinson. Now, there are some other features that are helpful. Responsiveness to levodopa is also very suggestive of the classical Parkinson. Micrographia, which means when you start writing, it gets very small. It's also very common in Parkinson. And asymmetry at onset is also very common. So for a Parkinson patient, they usually say they started on the right side and progressively over time is pressed to the other. If you have a patient with Parkinson that from the beginning is bilateral, it's usually something else. So sometimes you can make the diagnosis just by looking at the patient coming to your room, shaking your hand. You see the classical posture. They can have resting tremor that you can see while they're walking. They tend to have this forward tilt, reduced arm swing when they move, and the shuffling gait, which is very characteristic. So again, this is just to review some of the basic findings in Parkinson's disease. So basically, they're asking this patient to do repetitive movements, like foot tapping. This is on the left, and compare how he's going to do it on the right. So a lot slower. That's called bradykinesia. And it's asymmetric. If you look how he's walking, you see that the right arm doesn't move as much as the left. You can see how he swings the left but not the right. Is it the classical resting tremor or heel rolling? It's a little bit more dramatic.
Okay, don't worry about that. That way we can see. I don't like it, but that way we can see how it is. Open and close your hands as fast as you can.
So this one is called dyskinesias. You see that he's being asked to move his hand, and he's moving his head and his legs. This is an involuntary movement, and these are dyskinesias induced by movement. The same here, he's being asked to move his hands, and you see how his legs can stop moving. So when you have advanced Parkinson, you go through these on and off symptoms. And basically this is off. Basically patients are very rigid, very slow to move. You see he's being asked to just walk. You see how stiff it is. There's some freezing of the gait, there's a shuffling, there's pretty much no arm swing. And you're going to see the same patient walking during an on period.
We're going to go walking.
So that's exactly the same patient, but this is in an on stage. And you see that on and off frequently in advanced stages of the disease when they've been receiving levodopa for long periods of time. So in terms of the progression of Parkinson, we know that there's some preclinical changes. Usually patients start developing symptoms when you've lost about 50% of their neurons in the substantia nigra. Then you get diagnosed, hopefully, and you go what is called the honeymoon period, which means you get symptoms, you start on medication, you feel great. Sometimes they completely go away, or at least 90, 80%. But then you're going to go through a period of time of wearing off, which means the medications are not as effective as they used to be. So you start requiring more medications, or increased frequency or higher doses. And then you get into what is called the motor complications, which include the wearing off, the on and off dyskinesia, like the one that I showed you in the video. Then at some point, levodopa, which is the mainstay treatment, stop being effective. And often at the end, cognitive decline or dementia associated with Parkinson can develop. So what are some of the main differential diagnoses for Parkinson? Essential tremor is probably one of the most common. This is postural and action tremor. So instead of the Parkinson, which is a rest, this one develops when you ask the patient to either maintain a posture or when you ask him to do something. Essential tremor doesn't have any other neurological findings, so there's no rigidity, there's no bradykinesia, there's nothing else. Interestingly, it tends to respond to alcohol. Again, not that I encourage patients to start drinking, but they feel better. And frequently, 50% of patients have family history of essential tremor, so that's also helpful. Vascular Parkinsonism. So we get into the Parkinsonism, which means they look like Parkinson, but it's not the classical form. So if you have multiple strokes, either major ones or small strokes in the brain, you can develop vascular Parkinsonism. It tends to have a more stepwise progression. And you tend to see focal neurological findings related to the location of the strokes. An important one, now that everybody's taking psychotropics, is medication-induced Parkinsonism. We see that a lot. And it's basically patients that are taking neuroleptics, and they look like Parkinson. They're stiff, they're rigid, they have the tremors, and basically you take them off, it goes away.
Right. Thank you so much. So we're going to meet? Yes.
And another one is the dementia with Lewy body. The key here is that the onset of cognitive symptoms is very closely related to the motor symptoms, usually within a year. And they also have frequently visual hallucinations early on. They have prominent fluctuations in attention and cognition. And something that also helps is that they don't tend to respond to levodopa. So these are kind of the red flags to tell you this probably is not Parkinson. If you have early prominent gait and speech disturbances, it's probably not the classical Parkinson. It can be an associated disorder. If you have a lot of postural instability, what that means is that they fall very easily from the beginning. If the rigidity is more the axial muscles than the limb muscles, that's also atypical for Parkinson. If you have prominent autonomic dysfunction, which means bladder, bowel, sweating, salivation, erectile dysfunction, all that, if it's very prominent and very early, that may suggest something like multiple system atrophy. And whenever you see a patient that at the beginning doesn't respond to levodopa, it's probably not Parkinson. It's probably something else. So in terms of what kind of diagnostic evaluation you can do in these patients, this is a review, the common tests performed. Really, the diagnosis of Parkinson is clinical diagnosis. You frequently do an MRI to exclude other things like vascular Parkinsonism, but again, a classical history is probably all you need. There are studies with PET scan or SPEC. This is mainly used for research. The SPEC can be useful sometimes to differentiate those cases of essential tremor that may look very similar to Parkinson. Sometimes it's hard to differentiate. The SPEC can help you. And we're getting close to, there have been several studies published of looking to skin biopsies, and you can measure the protein, so you can measure alpha-synuclein protein in skin biopsy. And although this is not clinical standards, there are several reports showing that it can be an effective tool in the future for diagnosis of Parkinson. So in terms of treatments that you can use, the first question that you have to ask is, should you start medications? If a patient has very mild symptoms of Parkinson, you may not need to. So the American Academy of Neurology recommends to start treatment once there's some type of functional disability. And it can be something simple. If a patient has difficulty writing, for example, it may be not a lot of symptoms, but it's affecting his normal lifestyle. And there are a lot of studies trying to look for neuroprotective agents, and patients sometimes ask you about that. And the reality is no component has been established as neuroprotective. So what are the options? What medications can you use for Parkinson? The main standard is levodopa, always given with carbidopa. Dopaminergic agonists can be used, or MAOB inhibitors. So we'll go over those. So carbidopa, levodopa is the gold standard for management of Parkinson. It's the most effective. It improves disability, but it has problems, especially over time. So long-term use of levodopa in these patients is going to lead to motor fluctuations, which means dyskinesias, so when they're on, when they're very shaky, or wearing out when they're extremely rigid and they can hardly move. Other non-motor complications of levodopa, hypertension, and hallucinations can occur. So the idea is, if a patient is over 65, and this is kind of an arbitrary number, we tend to start with levodopa because the life expectancy and the time of onset of long-term complications is still favorable. But if you have a young patient, meaning 50, 55, you probably want to start with something else before putting him on levodopa. So the dopamine agonists that we have available, pramipexole and ropinirole, are the most widely used. They can be used as monotherapy or as add-on therapy. They can be combined with the others. It has less risk of motor complications, so that's the big advantage. The disadvantage is that it's not as effective. It helps, but it's not as powerful as levodopa. They can also have dopaminergic symptoms, nausea, vomiting, and orthostatic hypotension. You can have that with any dopaminergic agent. Neuropsychiatric symptoms can occur, and those are interesting. Sometimes they have compulsive behaviors. Compulsive gambling has been described. Somnolence, and as I mentioned, not as effective as levodopa. And the third group of medication that you can use as a monotherapy would be the MAOB inhibitors. Selegiline and rasagiline are the most commonly used. If you're going to use it as monotherapy, it has to be very mild symptoms of Parkinson. It has a lot of interactions with other medications. You've got to be very careful because it can increase the possibility of side effects. And as I mentioned, they're not as strong, but you can use it as a coadjuvant medication, so something that you can add on to. Now the COMT inhibitors can be used in combination with levodopa only, and the most commonly used is entacapone. Tolcapone is rarely used anymore. And the idea is when you're starting to have motor fluctuation, these on and off periods, you can add one of these so you can reduce the amount of levodopa that you're giving and hopefully decrease the possibility of those motor fluctuations. They can cause nausea, vomiting, orthostatic hypotension, and urine discoloration, as we report. Now, for certain symptoms, you can use specific medications. Like for dyskinesia, you can use amantadine, which is an NMDA receptor inhibitor. For tremor, just for the tremor, if it's a major problem, you can use anticholinergics, like benztropine or triacetylidine. The problem is it has a lot of cognitive side effects, so that can be an issue in elderly patients. But you have a young patient who has a lot of tremor, this would be a good option. Freezing of gait is a problem, and as the video showed you, the person had a lot of difficulty starting to move. There are certain strategies, or physical therapists are very good at it, and teaching patients certain tips to facilitate starting to move. So imagine you stand up and you're going to start walking and you can't get the first step. So you can teach the patient to alter his distribution of body weight, try to kind of lean back and forth. There are canes, for example, that have a laser point to the floor, and just to have that visual stimulation, it facilitates getting the next step. They can use verbal or auditory stimuli, like marching to a command like a soldier, walking to music, things like that. So there are interesting things that therapists can teach patients, so facilitate this freezing of gait that can be very disabling. And a lot of Parkinson patients have non-motor symptoms that need to be addressed, and that's also very important. Fatigue, a lot of patients complain about it. Methylphenidate can be used. Now you have to be careful with the potential side effects of methylphenidate, but it's an option. Management of depression, again, very common in Parkinson. There are studies with SSRIs and non-SSRIs. Amitriptyline has a good evidence, but you also have to worry about the anticholinergic and cognitive effects. Now, patients that develop dementia associated with Parkinson's disease, rivastigmine is FDA approved for this indication, and there are also studies with donepezil. Orthostatic hypotension, it can be primary to the disease. A patient with Parkinson can have it, or can be caused by the medication that we use to treat it. So if you think that is more a side effect of medication, you can try to adjust it first. Other thing that you can use is compression stockings, increase water intake as long as it's safe. I mean, you have to think about comorbidities, CHF, etc. Medication that you can use for symptomatic orthostatic hypotension, midodrine or fluorocortisone, and again, you have to be very careful about the cardiovascular status of the patient. Hallucinations in Parkinson's, so the same principle applies. First, think about it, is it medication related? If not, there are only two medications that I will use in patients with Parkinson and hallucinations. And remember, you don't need to treat all hallucinations, mainly those that are refractory to the treatment, especially those that tend to be very aggressive behavior. So clozapine is the most effective of all these medications. The problem is there's a FDA black box warning for the use of clozapine associated with severe agranulocytosis and liver failure. So it implies that you have to get CBC and LFTs every week for the duration of treatment, which, as you can imagine, is very painful to do so. The alternative is quetiapine. Again, it's not as effective. It tends to cause more somnolence, but it's the first choice that I use because it's just easier to manage. So that's the caveat. You don't use any of the others. You will never use Haldol, Risperdal, or any of those olanzapine because they're going to aggravate the symptoms of Parkinson. So then you get to the other side.
Can I ask a question on the quetiapine? If you start at a low dose and go up slowly, do you have as much problem with the somnolence?
We always start that way, start with very low and graduate. Some patients with a very low dose, they're very somnolent. You have to titrate, but yes, that's true. You start with a low dose and there's no rush to go to a higher dose, and they can develop tolerance to the somnolence. So non-motor symptoms, also sexual dysfunction. Sildenafil has been used. Insomnia. Again, you're going to be careful in terms of some of the side effects of sleep medications. But there are studies with Zolpidem, Xalapon, and Zopiclone. Melatonin is frequently used just because it's safe. There was one particular study showing if it was effective in Parkinson, didn't show a lot of benefit. You know, in general, melatonin effect is not as strong as other medications, but it's at least safer to use. RAIN behavior disorder is commonly seen in Parkinson. RAIN behavior disorder means that the patient basically acts their dreams, and basically, you know, during sleep when you're dreaming, you're paralyzed, so you can move, only you move your eyes and your breathing muscles. But with RAIN behavior disorder, you lose that ability to be paralyzed during sleep. And basically, these patients tend to have nightmares, and they start kicking and fighting and jumping out of the window. And usually the person that complains about it is the wife or the spouse, because sometimes they're being attacked during sleep. So for that type of behavior, you can use clonazepam. There are some melatonin you can use. Nausea can be associated with a lot of the medications that we use for Parkinson's, so you can use domperidone. Daytime somnolence, most commonly caused by medications. There are some studies with modafinil for this particular indication. And then we get to surgery. You probably heard more and more deep brain stimulation is being used for management of Parkinson's disease. So the idea of using deep brain stimulation is to improve off time. And the average in the studies is 4 to 6 hours of improving off time. So you may not see it as much, but having 6 hours of a day that you can actually move and do things is a huge difference for patients. So who is a candidate for it? And so far the indication is patients who still respond to levodopa. So that's important. If a patient doesn't respond at all, even for 30 minutes or an hour to levodopa, it's probably not a good candidate. That they have on and off fluctuations. So they go through these periods of time or too much movement or no movement at all. That the dyskinesia, these involuntary movements, are affecting the quality of life. That the tremor is resistant to medications, and that they have a good cognitive function. So those are the indications to consider deep brain stimulation. And it's very effective, and it's more and more used nowadays. And then you get to, all right, what patients with Parkinson who reach a state that none of these therapies are a good option, then you have to think about palliative care. And the principles of palliative care in patients with Parkinson are pretty much the same that in other conditions. You want to relieve pain and other distressing symptoms. It's intended to facilitate care, and so caregivers is a big part of palliative care. Support system, using a team approach, integrating psychological and spiritual aspects of patient care. So when do you consider palliative care evaluation in a patient with Parkinson? So there's a classification that we use in Parkinson. It's called the Hoehn-Yahr stage. It goes from 1 to 4. And the stage 3, which is advanced Parkinson with significant limitations in mobility, that is bilateral, affecting both sides of the body. So that will be a consideration. Patients have dementia associated or psychosis. Well, then you see that the caregivers are going through a very significant difficulty managing the patient. Swallowing difficulties, recurrent infections, weight loss, or when they have multiple comorbid conditions that make it very difficult to attend. So those are considerations to consider palliative care in Parkinson. So the palliative care especially provide emotional support, caregiving support, helps with communication difficulties, manage the terminal symptoms, and helps with the emergent care. So predicting death is hard in any condition, in Parkinson is particular. So the most common cause of death is aspiration pneumonia. Other frequent comorbidities, recurrent urinary infections, falls, delirium. The only good predictor for death in Parkinson is food refusal or mutism outside the context of delirium and infection. It's often a sign of imminent death within 2 weeks. So if you're going to manage in terms of palliative care of these patients, you tend to address musculoskeletal pain, which is common. Remember, these patients are very rigid, so that they can develop contractures. And those you can manage with therapies, with medications for pain. Sometimes for contraction, you can use botulinum toxin. Constipation, another common complaint, or sleep problems. So you try to address all these symptoms that it's not primarily the disease, but it make a huge impact in the quality of life.
Excuse me.
Yeah.
Do they respond to physical therapy?
Do they respond? Depends. It's case by case. It depends on, we're talking about palliative care. Yeah, well, we tend to start early. Preventing contractions is probably a better idea than waiting for a contraction to happen. But, you know, we receive patients at any stage. So at least I get an initial physical therapy evaluation and see if we can address some of these problems. And I also, I use therapy a lot at different stages of the disease. Because our therapists are very good at addressing some of the fall prevention, giving them strategies for managing that, the freezing of gait, for example, that I mentioned. So I tend to incorporate therapy during different stages of the disease.
And I was wondering if you could speak to the possibilities of the viral etiology?
Which one?
Viral etiology?
Viral etiology, well, it has been many different possible causes have been addressed, but there's, besides the genetic factors and some environmental factors that increase the risk of Parkinson, no particular virus has been addressed as a cause of Parkinson. All right, so I'm going to jump to a totally different neurodegenerative disorder, and this is ALS. And ALS, as a neurodegenerative disorder, as I mentioned before, affects the motor neurons, so it's primarily causing muscle weakness. And the basic mechanism is dysfunction of the upper and lower motor neurons. So when I say upper motor neuron, is the one that's in the brain that communicates with the lower motor neuron that is at the spinal cord level. And the combination of findings, both upper and lower, is what makes the diagnosis of ALS. They tend to have relatively preserved sensory function because the muscles affected can be the bulbar muscles. Dysphagia or dysarthria are very common, but it can happen at different stages. Some patients in the initial presentation, some others is later on. Weight loss is very common. And they can also have symptoms of chronic hypoventilation because these patients have weakness of the respiratory muscles. They can present with morning headaches, fatigue, daytime somnolence, etc. So this is some examples of one of the lower motor neuron findings is atrophy, meaning loss of muscle. So you compare, there's a significant atrophy of the first distal interossei on this hand, and this is a comparison compared with the left hand. And you can see this atrophy in different parts of the body. They often have fasciculations. So one place that you always look is the tongue. This tongue is atropic. This used to be a video that basically you can see how it moves spontaneously. So those tongue fasciculations are very suggestive, but you can have fasciculations anywhere in your body. And depending on what motor neuron is affected, you can have different spectrum of the disease. So as I mentioned, classical ALS is upper and lower motor neuron. But if you have purely upper motor neuron findings, it's called PLS, or primary lateral sclerosis. And that tends to have a slightly better prognosis compared with the classical ALS in terms of survival. Lower motor neuron, if it's pure lower motor neuron, it's called progressive muscular atrophy. And if it's purely bulbar, you call it progressive bulbar palsy. Again, a lot of these two tend to just to progress to classic ALS, so it's just that the disease starts that way. And some patients with PLS will also go to ALS. So how do we manage patients with ALS? We have multidisciplinary ALS clinics, and that per se has been shown to improve the care and quality of life of patients with this disease. It incorporates not only neurologists, pulmonary doctors, therapists, nutritionists, psychological support, and social workers. So the American Academy of Neurology recommends the use of the specialized multidisciplinary clinics for management of these patients, as different studies have shown improving healthcare delivery and prolonged survival. A lot of what we do in ALS is symptom management. So patients can have what is called pseudobulbar affect, or PDA, and basically it is, I call it emotional incontinence. It's patients who start laughing or crying without any particular triggers, or very minor triggers. And if it's crying, a lot of times the family think that they're depressed, and that's why they're crying so much. But it's just an involuntary release of their emotions. And there are specific treatments for that. The combination of dextromethorphan and quinidine has been effective. Amitriptyline has also been effective. Sialorrhea is also very common because of the weakness of the oropharyngeal muscles. So we can use anticholinergics, scopolamine patch, botulinum toxic injections to the salivary glands, or for extreme cases, radiation therapy has also been used.
Sir, I have a question on that. Are they
Yeah.
crying or are they tearing?
No, it's crying.
So like,
Yeah,
the
you see them and you
emotions
see
are
like
there
crying.
as well.
Yeah,
Okay, thank you.
it's a crying and emotion, and it looks like it's a very intense emotion, but the trigger is basically nothing. Fatigue, very common in ALS. It can be related to the disease. It can be a sign of chronic hypoventilation, so you always check the ventilatory status, because that may be a marker to say that this patient is probably not oxygenating well at night and they need some type of supportive device. You have to address other symptoms, depression and anxiety, pain, cramps. Just a word about cramps. We try everything and nothing really helps much. Tonic water is something that you can recommend. It has a little bit of quinine on it. There are studies with gabapentin, riluzole, vitamin E, specifically for cramps in ALS. None of them show being effective. In the past, we used to use quinidine for cramps, but the FDA decided that it's too risky because of the cardiovascular risk, so it's not authorized its use outside cardiovascular indications. Spasticity can be a big problem for patients with ALS, so you can use baclofen, thiosanidine, or benzodiazepines for management of spasticity. Decreased mobility, so that's when we have therapies. We use assisted devices for ambulation or orthotics. We address the dysarthria and communication problems early on. We advocate the use of voice bank. So basically, while the patient still has adequate communication, they can say their voice, and that can be used for future communication devices. Cognitive impairment and dementia can happen in ALS. Not all patients, but I mentioned before the association between certain types of frontotemporal dementia and ALS. And also patients without that particular pattern can also have cognitive impairment. There's only one medication that is FDA approved for the treatment of ALS, and it's called riluzole. The studies, what it shows is that it improves tracheostomy-free survival within 2 to 3 months. So a very modest effect. And there is no symptomatic improvement by taking the medication. The two main things that you have to address in patients with ALS is nutrition and respiratory management. So one of the most common questions is, when do you pet affect you? Number one, if the patient is willing to. At some point of the disease, when the dysarthria is very prominent, when the dysphagia is prominent. Now, ideally, you want to put the peg when your forced vital capacity is still 50% or higher. That decreases the risk of complications. Now, that doesn't mean that if you have a 45% or a 40%, that you cannot do it. It's just that it has a little bit more risk of complications. And I know there's a lot of controversy if you have a pedicure with a terminal condition, but it really improves the quality of lab and caregiver load in terms of management of these patients. So we are advocating for the use of feeding tubes when it's necessary. And the other is ventilation. So you can have invasive ventilation like a tracheostomy or non-invasive ventilation like a BiPAP. Non-invasive ventilation is possibly effective in raising quality of life in patients with ALS who have signs of respiratory insufficiency. In the use of tracheostomy is more controversial. It depends on the wishes of the patient. What I've seen is younger patients tend to go more to tracheostomy than older patients, but everybody's different. And here is a point that the family and patient wishes take a big part. And at some point, patients are going to require hospice care. Basically, to start hospice care, you need to establish order for DNR. You may consider for patients who have progressive dysphagia and that they don't want a PEG tube, so you may want to start them on hospice. If they have progressive respiratory compromise, even with ventilatory support. Those who have severe chronic pain, and remember, ALS per se doesn't hurt, but because of the lack of mobility, they frequently have problems with contractures, joint pain. Is extremely common, so you have to address that. If the family is unable to care of the patients or there are other medical problems that are contributing to the status of the patient, you may want to consider hospice too. Now, Medicare has very specific guidelines for hospice criteria for ALS. So you have to have at least one of these. Critically impaired breathing capacity as demonstrated by one of the following. Forced vital capacity less than 30%, dyspnea or rest, and those who decline mechanical ventilation. Number 2A, rapid progression and critical nutritional impairment. So rapid progression means patients that quickly are going from independent to wheelchair to bedbound. And how fast is rapid? That's a little bit more adjustment criteria. There's no specific months. Progression from normal to barely intelligible speech. Progression from normal to puree diet, or needing a major assistance for ADLs. Of critical nutrition impairment as demonstrated by all of the following: oral intake insufficient to maintain life, continued weight loss, dehydration, or absence artificial feeding method sufficient to sustain life. And the third criteria is both rapid progression and one life-threatening complication, like one episode of recurrent aspiration pneumonia, the cubitus ulcers, recurrent fevers after antibiotics, or inability to maintain sufficient fluid and caloric intake. So those are the criteria for Medicare hospice. And I'm going to switch to the third neurodegenerative disorder, Huntington chorea. So I tried to give you a little bit of everything. So let me show you a patient with chorea. So patients with Huntington chorea has three basic syndromes. They have dementia, they have behavioral problems, and they have the movement disorder, which the most common manifestation is the chorea. And chorea basically is this involuntary, almost dyskinetic movements that the patient can really control. Sometimes what they do is they try to incorporate to an actual movement. So for example, if the hand starts moving, they try to do something with the hand just to kind of compensate. You can have chorea of the face, facial muscles, the tongue. You can have chorea of the arms and legs. So Huntington disease is an autosomal dominant condition. Prevalence is 4.4 to 7 per 100,000. The diagnosis is confirmed with DNA testing. And so try to repeat. Oops. But remember, 10% have no previous family history. You can have the spontaneous mutation. You can be the lucky one. So you have to have a family history to say that it's Huntington. And the movement disorder, chorea is by far the most common manifestation, but they can have also other movement disorder like dystonia, myoclonus, tremor, and rigidity. And actually in the younger young onset Huntington, like it represents in the 20s, they tend to have more of the rigidity, so they look more like Parkinson than actual chorea. Psychiatric manifestations are very common. Depression is the most common, but aggressiveness can develop in about 50% of patients at some point of the disease. Obsessive compulsive behavior, again, very common, anxiety and psychosis. And the third element is the dementia, which memory loss, slow responses. Interestingly, language tends to be preserved until later on of the disease, and they have early loss of executive functioning. So the idea of the treatment of Huntington in terms of palliative care is that the good days should outnumber the not so good ones. And you treat motor and psychiatric manifestations, and you make sure that the environment is safe. This patient has higher risk of suicide, a higher risk of injuring themselves. So you have to be careful about that. So nutrition is a big problem. They tend to spend about 4,000 to 5,000 calories per day. So you have to eat a lot to compensate that kind of caloric loss. And often they may have swallowing difficulties, so that makes it even more complicated. Now here the feeding tube is much more controversial. It depends on what stage of the disease the patient is, what are the expectations of the patient and family. Sleep is a big issue also in the care of these patients. You have to establish a very detailed pre-bedtime routine. Remember, they have a lot of times obsessive compulsive behavior, so you have to work on that. Benzodiazepines may help with the sleep and anxiety. For the movement disorder per se, for the chorea, tetrabenazine is FDA approved for this indication. This is how you start, a low dose and gradually increase. Side effects, worsening depression and suicidal ideation. Other medications that have been used for chorea is amantadine and psychosis, as I mentioned, the psychiatric symptoms are common. The medication that has been studied the most is olanzapine, but you can use the others. Parkinsonism, if they have Parkinson type symptoms, you can use dopaminergic agonists or levodopa. But remember, that can increase also your risk of hallucinations, so you gotta be careful. Management of depression with SSRIs or NSRIs, tricyclics or mood stabilizers. About a third of patients end up in an institution because of the significant dementia and psychiatric symptoms. The most common cause of that is pneumonia, aspiration pneumonia, or other infections. And a lot of times these patients have seen their parents die of the disease. So you can imagine if you saw your mom or your dad going through this process of getting demented with psychiatric manifestations on the chorea, and you know that you have the early symptoms, it's extremely hard on them. And also you have to address that there may be a potential risk that the next generation can be affected. Most patients don't start having symptoms by age 40. That's the most common age of onset. So by that time, you already have kids in most cases. So you have to address those issues. Common signs of that the end is near weight loss despite high caloric intake, repeat infections, or excessive somnolence. So I think that's it I have for today. I'll be happy to take any questions. Again, there's a lot of research being in all these conditions, and I think in the future we're going to have more alternatives and more understanding about what's the cause of these disorders, how we can better approach them. Thank you.
Any questions? All right, I'm bringing my clock.
I just had a question about what is the, I guess, to clarify the main determining factor, the difference between the ALS and Huntington?
Okay, ALS is purely a motor disorder, which means it's characterized by weakness, and weakness of the arm muscles, leg muscles, respiratory muscles, or bulbar muscles. Huntington is a combination of a movement disorder. When I say movement disorder, it's not weakness, it's just that they have this chorea or tremors or dystonia. They have dementia and they have the psychiatric symptoms, and you don't tend to see those with Huntington, well, with ALS. So in terms of how you make the diagnosis is very different. Any other questions?
Thanks for the
All right.
memory.
Thank you.
Swingy cartoons, motor trips, and burning lips, and burning toast and prunes.
How lovely it was. Thanks for the memory of candlelight and wine, castles on the Rhine.